So let me just have a brief introduction, and then we will start with the session. So basically, Dr. Subhasis Banerjee is a senior AI scientist at GE Healthcare. He has over 12 years of experience in applied AI, ML, spanning in healthcare and fintech domains. Previously, he worked as an AVP at Group VPCE. He earned his PhD from the Machine Learning Intelligence Unit at ISI Kolkata and completed postdoctoral research at Uppsala University, Sweden. Subhasis has published more than 30 research papers in top tier journals and conferences, holds multiple patents, and serves as a reviewer and editor for various academic journals and conferences. So, basically, with this brief introduction, I would like to hand over the session to Dr. Subhasis, sir. So, over to you, sir.
Thank you, Vikas. Let me try to share my screen. So my presentation is visible, right?
Sure,
So yeah, shall I start?
sir. Sure, sir.
Yeah. Okay. So yeah. So the title of the presentation is quantitative imaging biomarker, the real role of radiomics in brain cancer. So let me first start with that radiomic, defining the radiomic. So radiomic basically started around 2016 with this paper called "Images Are More Than Pictures," so by JD et al. So there they have shown that radiological images can't be mined thoroughly to extract meaningful representations like features, and that further could be useful for diagnosis prognosis purpose. So if we just try to make a definition out of this, what is a radiomic? Radiomic refers to the computerized extraction of quantifiable data. Quantifiable data means the features, quantifiable features from radiological images using several data characterization algorithms. So you have the raw image. From there, you have to define some sort of algorithm or formulas to extract the features, and those features further can be used for different purposes like diagnosis, prognosis, response, like during the treatment, what is the response to measure that. You can use longitudinal features as well. So here is a like a small pictorial representation of that, where you can see this is a brain MR image where there is a tumor. So if we just like extract imaging features, so what I'm meaning by imaging feature I will come to next. But if we just extract different features from that, then that could be useful to take some decision based on those features. So this is briefly what is radiomic. And this basically in 2021, when WHO released their new guideline for brain tumors or central nervous system tumor classification. So that is basically where it came into like existence, that not only microscope based or kind of normal tissue sample based, biopsy based classification is important, but along with that we should also consider molecular pattern or molecular representation. So as you can see here, previously in 2016's report there are straightforward four classes, grade 1 to grade 4, and each of them are considered as malignant. But in 2021 they removed grade 1, they called it not malignant tumor. But from 2 to 3 there are different subcategorization of that also. Like suppose this is a brain tumor, in that case you have to find out whether the IDH gene has been mutated or not. So if it's mutated, then there is a path. If not mutated, there is wild type, there is another path. So based on that, it's wild type and it has some more characteristics. Based on that, we can call it straightforward glioblastoma, that is grade 4 and deadliest tumor. And if it's mutated within that regime also, there can be further segregation of different types of like grade 2 to 3, or even if there are some like mutated case with some more other genes are also mutated, those cases are straightforward goes into grade 4 glioblastoma or astrocytoma. So this is a very complex diagram. This is a simpler representation of that. But if you go through this report, so it's not only considering that microscope based or like biopsy based culture of the tumor, but also take into consideration some other factors. So basically, then the radiomic features, the researchers are trying to make some correlations that came into like picture during 2021. That since radiomic features already have shown a strong correlation with the geometric alterations, means like with maybe with this IDH gene. Research has already shown that it's a very strong correlate with the radiomic features. So people start thinking that we could complementary use that radiomic feature along with that like biopsy based tissue sampling to further classify or make some decision on those tumors. So that was the whole idea. And there is another term. So when we are like combining radiomic means the features coming from radiological images like MR, CT, PET, and when we combine it with biological information or genomic information, then it's called radiogenomic totally. So this is find out the correlation between two feature classes. One is the imaging based feature, one is the gene expression based features. And when there we find the correlation between them, we call it through radiogenomic study. So if we just go step by step, how to like propose a radiomic solution. So I'm talking about brain tumor, but you can extend it or you can apply it in any case, any cancer, even without cancer for any disease. The same pipeline you can follow. So it started from like image acquisition. So first you have to acquire the image of the, like suppose a patient having some brain tumor, it's gone through some MRI scans. So MRI are as you know there are can be multiple contrast defining or visualize different component of a tumor. So suppose in a MR scan called T1 weighted scan, if the whole tumor is visible, some of its component like necrotic region, maybe enhancement, that region is still growing. To visualize that appropriately, you have to inject some contrast. So with T1 injecting contrast, you will get another sequence. Maybe sometimes it appears that most of the deadliest tumors are forming around the cerebrum. So this is the region where if we like take a T2 weighted image, it's this is a T2 weighted image where this region and also the tumor region is highlighted. But you want to only see the tumor region. In that case, you have to nullify the CSF signals. So that becomes like T2 weighted flare sequence for that. So there are like 4 or 5 sequences you can consider, like T1 contrast, T2 flare, then diffusion weighted images. So this is start like first step. You have to acquire the images. Then since like you can acquire the images in any scanner, any setup. So these are not properly standardized. Standardized means there are multiple things can be happen, like it's not standardized with respect to a standard atlas. So suppose since you will be using that image to further analyze, and you don't only use only one image. You have multiple patient data coming from different sites, different scanners. So you have to follow, or you have to first standardize them to a fixed atlas. Like this, there are multiple atlas, MNI is one. So the first, we have to register the image such that the regions, like suppose this is the skull, so it will suppose we are registering both image, and then skulls region should be matched, and then CSF also accordingly, and gray matter, white matter, some other tissues will be falling within that region. So it's become more standardized. So this is first step. We have to standardize through some registration basically, and then it requires some pre-processing. So in pre-processing, what we will do, we usually remove the skull. So this region, the skull region, is removed. So this not very much important, not for your radiomic analysis. Since you are analyzing some tumors within the brain, you can keep it. But it's standard practice that people remove the skull region, and also denoise the image little bit. And there are different artifacts in the MR scans. You will find that, like there is a bias field. If there are motions, you have to like standardize based on that. You have to remove the bias field. You have to removes or you have to try to normalize the motion if motion is coming to the like image. So those things are goes into the pre-processing steps, and along with that there should be a step called intensity standardization. So since you are like acquiring or using MR scans from multiple sites, so you have to normalize the intensity or standardize the intensity. So you can like use maybe min max or just normalizations, any statistical normalization or standardization to make the intensity range of the images in a like fixed 0 to 1 maybe, or 0 to 255 in that scale. So these are the two like kind of pre-processing and the image acquisition steps. So after you have prepared your data set, so this from the raw data set, you have pre-processed the image, and you have your data set prepared and pre-processed data set. Now on that you can start doing the radiomic analysis. So in the radiomic pipeline, the third step is the most important step, that is the segmentation of the region of interest. Segmentation. Suppose this is your brain MR images where you have the tumor region, right? And the final goal is you have to extract the features. Those features you will use further to make the decision. But you will not extract feature from whole image. So for that you have to extract the region of interest or segment the region of interest. So there is a in a most of the medical image analysis field, so this segmentation is very crucial, very much important to identify. Maybe it's a kind of loose segmentation, that is kind of bounding box around the tumor, or a very refined segmentation finding out the contour around the tumor. So in our case, since it's a kind of tumor region that we are going to analyze, we should do a fine segmentation of the tumor region. And there are big challenges like breast challenge, brain tumor segmentation challenge. Every year they organize, and many people from academia, from industry participate to the challenge. So some of you might know that. So those challenges, they released data set, already pre-processed data set. So they acquired the raw data from different sources, and they pre-process the data set and release the training set to the audience or to the participants. And you can develop your model, like segmentation model, on using that data set, and then like submit the result or submit your model weight to them. So they will evaluate and they will give you scores accordingly. So here I am showing tumor habitat. Tumor habitat means in a glioblastoma brain tumor, it's not a pure solid tumors. There are subcomponents within that. Like as you can see, these are the components: necrotic region, or non-enhancement region, enhancing tumor region. So enhancing region is the crucial region where the tumor is still tissues are still growing, and necrotic is the internal part that is mostly rotten tissues. And edema is swelling and around the periphery of the tumor. So there are like terms like whole tumor, tumor core. So tumor core basically consists of these two things, and whole tumor you can consider. So all the tumor components. So I was mentioning about breast challenge. So breast challenge, there are multiple challenge. One challenge is to segment the whole tumor. One challenge is only segment the core. So as you can see, segmenting whole tumor sometimes is easier compared to segmenting the tumor core region, this part, since it's totally diffused and very hard to, like, there is no fixed contour or fixed boundary that you can. So it's even for very good right now, we have many deep learning based convolution neural network based or transformers architecture, but still they are struggling to segment this region, tumor core region. And so after, so this is a 3D representation of the same thing like previously I was showing in 2D. So in 2D you can so medical images like MR images is a 3D kind of sequence wise 3D, or this is a whole 3D acquisition. You can consider as a cube where you can go slice wise, that we can take any direction like axial, sagittal, and coronal, or even in 3D you can see like this. So this is tumor habitat in 3 dimensional, like enhancing tumor, necrotic, and edema. So then the so yeah, this is the main crucial step in a radiomic analysis, that is the segmentation of the region of interest. Then comes like feature extraction and feature selection and machine learning. So let me show you one demo segmentation. So for segmentation, there are many tools that you can use, or you can develop your own. So there is a very good tool called 3D Slicer. So this is a like demo data set already available there, brain tumor segmentation. So here in this like video, you can see how to segment through this tool. So you can load the data. So there, this is the annotation. So you have to define two levels. One is the internal level within the tumor, and outside anything you just mark like this. So this is the background levels, foreground and background you have to mark. And then there is a algorithm called grow from seed. So it will give you a rough segmentation of the tumor, and it's in 3D. So then what you can do, you can just like modify it in 3D. There are different tools, so you can modify it in 3D. The extra regions you can move, and then you just rerun the grow from seed algorithm. So it will remove all this false positive things, and then you can also smoothen the tumor region a little bit, or if you can, yeah, go through the slices and see if it's missing some slices, you can manually correct that. So this we call semi supervised segmentation. So you are giving two seeds, foreground and background, and then the algorithm starting from there, generating rough segmentation that you manually modify. And this is not manual, full manual. So in case of full manual, you have to contour slice by slice, and it's a kind of like a very laborious task. So to ease out you can use like semi-supervised segmentation algorithms like this. And so this is semi-supervised. Then comes to the supervised segmentation. So supervised segmentation, the challenge is acquiring ground truth. Ground truth means you are having the MR scans, MR images. Correspondingly, you should have your segmentation mask for the tumor region. So if you have that data set like image along with the label, then you can use like deep learning based networks to train, and then after training you can use that network to like apply unknown samples where the label information or segmentation is not available. It can give you the segmentation. So some of the well known architectures were like pnet, unet, residual unet, and you can like change the convolution with transformers, and kind of similar architectures you can use. So in PNet, it's convolution based networks where it's very like optimized and very small network. So where it takes the input image and it goes through series of convolution and pooling, and after two set of convolution pooling, whatever feature it's generating, it's not reducing the feature. So it's all valid convolution it's doing, and then it's combining all into by concatenation. So it's generate from all the output from different features vector learned from different layers, different depth of the network, and then further we have a one cross one convolution that is basically again from the feature space to the image space, since it's like kind of going one image that is MR image and we'll get another image that is segmentation of the tumor region, that is a binary mask or multi-level mask. So that is the output image you are getting. So this is the PNet structure, and then you have the UNet structure. UNet is very popular in any segmentation, not only the medical images. So it's from that fully convolution neural network that proposed for computer vision communities for 17 segmentation. Then there is a Mickey paper that proposed that we can use unit structure for medical image segmentation, and there are many variations of that unit structure, and now there are modifications through transformers as well. But basically it is having two part. One is the encoder part, another one is the decoder part, and each of them are consist of couple of like convolution and pooling operations. And also in the decoder part it's just reverse. So when we are uh, doing the pooling, that is reducing the size of the image. In the reverse pooling, you are like from the smaller size you are going to the bigger. So that is the reverse, and this is the forward path of the unit structure. And the important thing here is the skip connection from the encoder to decoder. In the original fully connected neural network, there was not these connections are not proposed. So in medical domain, it's very important to whenever you are doing the max pooling to reduce the spatial dimension, and after that when you are again goes into the high resolution from a lower resolution, you just want to be like spatially validated. So for that, low level features are from the encoder networks are concatenate to the decoder network, such that during the decoding part or during the upsampling part, the spatial correlations should maintain. So that is taken care by the skip connections, and you can also make this network very deep through residual connection, as you get from this net. So those are like very well-known architectures. And I have some like I was participating the best challenge, and that time like 2019 when last participated, that time we just scores top four method using this ensemble of these three architectures. So these are very good architecture, and if you have sufficient amount of data set, you can also use some transformer based like layers within like unit structures, and that will give you very good accuracy. And we have discussed two things. One is the semi-supervised way of segmentation, or another one is the fully supervised way of segmentation. But the challenge semi-supervised is there are manual work. Each case when it's coming, you have to put foreground and background, and then it started. You can use that software to do a rough segmentation, and then you can remove the false positive things and make it more complete. So that is the, and then for the supervised techniques you should have the labels as well. But active learning based segmentation is proposed for mostly medical images where you can combine both. Like since at the beginning you don't have labeled data set, right? You just have the unlabeled data pool where you have just raw MR images. So what the you can do, you can use the 3D slicer based software to generate using the region growing segmentation that grow from seed. You can generate few images, few segmentations of few images. So you have a small annotation pool with labeled data, and you like maybe 5 cases you just first annotate, and then you try to train one CNN network. So maybe one unit, small variation of unit. After training, you can directly use that model. So when six case come, you have annotated until 1 to 5, then when number 6 came, you just first infer it through your network, and it will give you one rough segmentation. We are assuming it's not very defined, it's not, but it's okay. You can start from that, and then what you can do, you can use that segmentation and refine it more through your region growing segmentation, or manually correct few things, and that will be added to your label data pool. And again, this will goes into your iterative model training. So in active learning, what will happen, model will be trained in like background. Whenever you add one sample in your data pool, automatically a model training will be called, and model will start, one epoch will start, and then model weight will be updated. And this way actually, after maybe 30-40 samples when you have annotated through active learning, so model will be more mature, and you will get very good, start to getting very good segmentation. There you don't need to further define it, or if there are refinement, that is very small. So in this way actually, you can generate more labels for label data sets. So that is another strategy, active learning based segmentation strategy, that right now most of the cases people are following to generate the segmentations. And when you have the segmentation mask generated, then the next step is the extraction of the features. So you have the segmentation of the brain tumor, then you can start extracting the features. So features, so there is a big literature on radiomic features. So first one is qualitative or semantic features, that is mostly defined by radiologists or doctors. So they visually inspect the scans and they can measure those features. Maybe they can put those values in a spreadsheet. So I will discuss that, and then next are all image processing based features, that is you can extract using your computer program. And there is also a library called PyRadiomic. You can just install that and use it. It accepts NRRD, I think, or NIGZ file. That is a format. Medical images, you can store the DICOM images into that 3D format, and you can put that path, and it will generate the radiomic features for you. It will store in a CSV file. So it's very defined and easy right now. So let's first start discussing about qualitative features. So it's called Vasari features, or Vasari objective features. So this is the full form of that, but it's visually defined. So the purpose is to classify the different radiological patterns and establish radiogenomic correlation. So for that you can use this. So if you go through these feature descriptions, then you can see tumor location is a important feature. Maybe radiologists or doctors or surgeons see the image and they find out the tumor is this location within the brain. There are some like the brain is dividing into different temporal regions. So they can put this is the region, and also you can see like if it's having ceased contrast value of that region, enhancement quality, proportion of enhancing tumor. Suppose you have the enhancing tumors and whole tumor, so they can measure the proportion that 20% or 30%, 80%. So if enhancement is really big, then there is a chance it is a kind of bad tumor. So these are all visually inspected features, and mostly radiologists and doctors are they can like extract those features after seeing the images. So this is the qualitative features, and then next comes into our quantitative, that is computer based feature, that can be morphological, textual, functional. So in morphological features, mostly tumor contour, on where you have segmented, you can get the surface curvature of that and measure some of the statistics out of that. And textural also by texture analysis. And in the next, yeah, this slide actually I'm just putting whatever is there available in pi radiomic. So there are, I think, 7 classes. It started from first order statistics based features. So you have the segmented tumor mask, tumor regions, and first order statistics means basically you compute the histogram, so distribution of voxel intensity within the ROI. And you have the, if you have the histogram, then you can compute many first order statistics like mean, median, mode, skewness, energy, entropy. Those becomes your first order radiomic features. And since you have the segmentation, that segmentation is you can extract 2D slice wise or a 3D volume. So if you have you can, from the 2D slice wise segmentation, you can extract shape based features. So shape based features, you can like you have the idea like what can be done, like area, perimeter, major axis length. So those informations you can extract from 2D shape, 2D segmentation of the tumor region. And this is the texture feature called gray level co-occurrence matrix. So suppose you have a, in your image you have gray level range from 0 to 255. So you can define a matrix 0 to 255 cross 0 to 255, and you can compute the joint probability of occurrence of two gray levels, like 0 with 1, 0 with 2, 0 with 3, and how many times this this has occurred in a neighborhood, like 1 pixel with one, suppose 1 pixel with 0 value, and in its 8 neighborhood or 4 neighborhood, if 1 has appeared, how many times it has appeared. So you can compute like this and prepare that gray level co-occurrence matrix. And from there, that matrix actually you can extract different features, contrast, correlation, these things. Basically, those five first order statistics features you have extracted from your histogram, kind of similar features also you can try to extract from this metric, second order gray level co-occurrence matrix. And in the gray level run length matrix, it is defining a run. Means like suppose you have a pixel with value 1, and the next pixel also 1, third pixel also 1. So then it's different. It's changing its value. But 3 pixels you find that with same intensity range. So that becomes your run length 3. So 1 with run length 3. 1 will run length 4. How many times it has occurred? So that information goes into gray level run length matrix. And gray level side zone matrix. This is again, since in the within the image you can make some clusters based on your intensities, like that we call zones. So suppose you have defined you segment your image unsupervisedly and define different zones. Within those zones you can extract like quantitative imaging features. So this is zone based, and there are different features as well. So in this library, actually those are already implemented. You just need to install the library, and Whatever like features you want to extract, you can either mention, or it will give you all the features available for each of the feature classes. Likewise, neighboring gray tone difference, gray level dependence matrix, those are all kind of texture-based features, and it's mentioned there what are the features, how many you want to extract. You can use this library and extract the features. So this is the third step basically. Like after segmentation, you have to extract the features, and when you have the features, you can also combine the features with the Vasari features, or you can just go by your computational features. And when you have the features, all the features, then mainly you everybody knows, like whoever doing machine learning, you have the features. Now you can do a feature selection. So in case of feature selection, you can like before that also you can pre-process the your feature metric. Like you can remove highly correlated features, you can remove null values, those things. After that, when you have the big feature set, from there you can select feature, meaningful feature. There are many feature selection algorithm, machine learning algorithm you can try. Also there are like machine learning models that is kind of random forest and all, which is doing that. Even if you are many like number of features, they can put like most important feature, they can use that, utilize that to go into that final decision. And there you can further, you can use supervised or unsupervised. So since you have the, like suppose you have a leveled data set, where you have, suppose you are doing like preparing a model for classifying brain tumors into three different grades. So and for after the you have extracted the features, and you have the MRI. So in that MRI images are labeled with high, low, or 1, 2, 3 values you have already. Then you can combine that level information with your feature information. So you have the features and you have the level. So that becomes your standard machine learning data set. And on top of that, you can apply an unsupervised algorithm, whatever like you want to see decision tree, maybe support vector machine or random forest. You can use them. Or if you don't have the labeled information and you just extracted the feature, you want to see if there are any like subclasses that you can form, you can go and like you can do a clustering using those feature set. And maybe if you find some prominating clusters, you can like yeah, you can conclude with some decision making that this tumor, there might be these are the subclasses or subcategories, and then you can try to correlate that information with clinical information and validate through clinicians. So it's too much difficult that also radiologists, doctors, they just see the images and internally what is going on. It's a very complex disease. It's still people are exploring new things every day. So even if you are like you come up with some new findings and you share with the doctors and radiologists, that might be helpful further. So these are two things we have discussed. One is radiomic approach, that is entirely image processing, image based approach, and there is another thing called radiogenomic. So where not only image, so you have the radiological images, then you can extract the tissues from the tumor, that is through the biopsy. And when you have the like gene expression or microarray expressions, with that you try to find the correlation of the imaging features, and also combining both you can like prepare a predictive model, and that could be useful for some purpose. So that is the integrated analysis through radiogenomics. This is another big field. So next, just I want to touch upon like deep radiomics. So still we have discussed handcrafted features. So where the feature descriptions are fixed, you have to like segment the tumor region, and from there you have to extract this information. So deep radiomic, that feature extraction you can put it, you can use a convolution neural network or deep learning based model to extract the feature. So you can either send a whole image like this to the CNN network or the transformer network and let the network learn the features by itself. So this is we call deep features. Or you can, what you can do, you can like do a rough segmentation or patch around the tumor and feed it to the network, but it's not fully unsupervised feature extraction. So you are segmenting the region of interest. If you are sending whole images, that is like feature learning is unsupervised. And you can also do a 3D kind of setup with multi-view or a 3D volume with the 3D convolution neural network you can do. And we have explored that previously, where we have analyzed also different layers of the CNN to verify that what the model is learning. And we are correlating, like suppose you see in convolution one features, it's learning, basically try to learning different brain tissues, gray matter, white matter, then that background, and this for tumor also is learning some filters. In the next convolution filters, we saw that we started learning enhancement tumors, like this is the enhancement region. So necrotic region started learning edema. So it's focusing more towards the intertumoral component. And then in the convolution 3, it's more towards like different texture and shapes of the tumor, based on which it's try to classify it either low grade glioma or high grade glioma. So this is a deep radiomic paradigm where the feature extraction you can like use a convolution neural network or deep neural network to do that. And yeah, so we have a handcrafted feature-based modeling, that is radiomic, based like shallow radiomic and then deep radiomic. And right now there are literatures where people are trying to combine both. You can use deep radiomic and also with the shallow or manually extracted features. You can combine both, and finally goes into the classification network. So it sometimes enhance your performance, but if you are using deep radiomic and you have a very good level data set, so the problem was with the deep radiomic, you have a large data set, level data set. Until unless you can't do a deep radiomic. If you have a small data set, then you can go to a like normal radiomic approach, and you extract the feature, select the feature, and then prepare train a model. So yes, so the next part I will briefly touch upon that application area of the radiomics. So mostly considering brain tumor. So there are diagnostic application, prognostic, and application in personal therapy. So these are the three. So in case of diagnostic application in the literature, broadly you can find like applying radiomic. Researchers are using radiomic to identify mutation status of different genes. Different genes that is highly correlates the brain tumor or brain cancer rates, and differentiating tumor based on texture analysis. That is another important aspect. Like in the scan, you can see there is a tumor. Now you have to identify or grade the tumor. In some patients, it's like in case of brain tumor also, doing biopsy is very tricky. Actually, it requires a huge pain to drill inside and then extract the tissue out of the tumor. Sometimes internally, if it's big, there is a chance of further clots and stroke. And also some patients are having this basically this biopsy, during that you have to do the anesthesia. So in some patients that are doing anesthesia and all, it's sometimes very challenging. So people try to find out like another path through radiomic analysis, that if they can do a classification of brain tumor through only the radiological images, and differentiating treatment effect and tumor recurrence. So this is another challenge. Like if patient is giving some medication or surgery or radiation, so there are chances that tumor can regrow, or there is a pseudo regeneration of the tumor region. To validate whether this is a pseudo or actual, this is another tricky task that researcher try to solve through radiomic analysis. I'll just put few papers whatever available on this literature. So this is one diagnostic application where researchers are trying to identify IDH status, that is whether IDH is a kind of gene, so whether it's a wild type or it's mutated. Suppose a patient having grade 2 or 3 glioma, even 4 grade 4 glioma, but the IDH is mutated, then the patient will survive more. If IDH is wild type, that is the deadliest thing, and the survival is 6 months only. So it's important to identify the IDH status. So there are works on that. It's mostly based on radiomic. Like you can see, these are the features: location, well-defined border, cystic change, edema, percent of edema, lack of enhancement. So those things they have measured, and along with some of the other radiomic features, and try to train a basic machine learning model to predict the IDH mutated for grade 2 gliomas. In grade 2 gliomas, this is the kind of boundary where if there is a IDH not mutated, then it's straightforward goes into grade 4 gliomas. Yeah, this is another paper, high values of the size ratio between the enhancing tumors and the necrotic. So I told previously that these are the two main components, like enhancement and the necrotic regions. And they just measure the ratio between two and use that as a feature to find out whether IDH is wild type or mutated. And this is a scientific report paper in 2020, and they have good accuracy on on that, using that feature only, and if they are predicting that IDH type. So then the next diagnostic application is basically texture analysis to find out the or grading the tumors, low grade glioma and high grade glioma. If you just consider the grade 4 as a high grade glioma and grade 2 to 3 as low grade glioma, then you can use texture features. After segmenting your tumor region, you can extract the texture features and use them to develop your machine learning or predictive models, and that could be through your CNN or deep learning based thing. So they are achieve very good accuracy on distinguish between low grade and high grade gliomas. So this is another application area where people are working. And this is the third one, and this is the most challenging one, where you can see this is the initial scan where you see the tumor. Then doctor surgeon do the surgery and remove the tumor region, and this is post surgical image. After 3 months, it appears there is some growing things like this, and now the issue is whether this is a pseudo progression or generation of the recurrence of the tumor region. So it's starting generating a new tumor. So to distinguish that, either you have to wait. So if it's a pseudo progression, then within couple of months it will go automatically. But it's a new tumor is coming, then within 3-4 months actually, then it needs to be again do a surgery or do some procedure. Otherwise waiting that long will worsen the survival of the patient. So to identify whether this is a pseudo progression or recurrence, people try to use the radiomic features along with the deep and handcrafted features, deep learning along with the handcrafted features, to find out whether this is a pseudo progression or recurrence of the tumors. And there are some literature showed that diffusion weighted or perfusion weighted MRIs. Since in case of perfusion weighted MRIs, the contrast travels through like blood, and it's if there is an enhancement can be very much seen on those images. So those sequences people are also used to distinguish that. But this is a very good application area. Many groups are actively right now working. So this is another diagnostic application. And in case of prognostic application, from the using the radiomic feature from the MR images, people try to get the overall survival or progression-free survival of the patient. So there are different studies on the glioblastoma. Even if there are very right now there are very good treatments are available, but still the progression or survival of a brain tumor patient, if it's a glioblastoma, is 12 to 14 months, and some cases very 6 months only. Researchers trying to segregate different survivals into different groups like low, median, high. So that we call survivor stratification. And along with the radiomic feature, you can also consider some of the clinical or some of the features like age, sex of the patient, those things. And there are survival analysis, that is you can also select different contrast or different MR sequences. Like here this study they have only used FLAIR T2 sequence, but you can also do it multi-parameterized using multiple MR sequences. And we have one study in the survival prediction group where we along with the radiomic feature we propose some other features like tumor habitat based features. So we like clustered the tumors into different symmetric regions, and then extract radiomic feature from those regions, and then we also divide the whole brain in terms of atlas, that is we call parcellation atlas based features. And from each of these we measure different quantitative measures like percentage of that region, the two different region, ratio of two different regions, and make a histogram and then extract the features out of those histograms. And then we did a thorough study only with radiomic with combination of different other features, habitat feature, parcellation features, using different like Cox net survival, the random survival forest. Those are the predictive modeling you can use for survival analysis. And we measured that like using all the features. So in combined, we are getting around 82% accuracies. And after feature selection, it's only 24 are useful. And we are also weighted those features like using a C index coding, like age is very important features it's coming out. And also as you can see, ratio of enhancement tumor, first order statistics from there, we have a couple of features from second order statistics from habitat. So these are all useful important features that is useful for your survival analysis. And we also visually like try to correlate those, like suppose tumor appears in a particular region, if it's correlate with the survival of the patient. So we have also done that study in this paper, and we have done Kaplan-Meier survival analysis using those statistics. So yeah, so radiomic, we have discussed radiomic, and that is even though it's proposed as an alternative to biopsy, but still it's there are some issues, and you can use it combination with the biopsy. And some cases where biopsy is very challenging, those cases it might be like give you additional information that doctors can take. But there are some limitations in this like radiomic approaches. Like if we just discuss about standardization, generalizability, and robustness, these three things. So robustness, basically there are two parts. One is repeatability and reproducibility. So standardization, still there is lack of standardization since in even definition of the radiomic feature. So even though there are some open source libraries, still people are defining their own features, and they're not reporting it or make it publicly available. So that is another standardization issue. If you are using some of the standardly available like PyRadiomic or this the cancer imaging kind of thing toolkits, so then it's more standardized towards, but there is still lack of standardization in this field. Along with the limitation, whenever you are defining a features, you have to make sure that it is repeatable. That is, a feature value remains same when imaged multiple time, even the same subject, and reproducible feature remain the same when extracted using different equipment software. Suppose you have extracted you are using different scans, then also the feature is reproducible. So these are the still limitation. Many of the radiomic features are not getting into reproducible or repeatable. This since this comes due to the pre-processing steps. So there is not standard pre-processing people are following. If you do a different level of pre-processing on your base raw level images, then you will get different representation or different quantitative value of that feature. So this is another limitation. And also in generalizability, if whatever you have developed for your suppose for brain tumors, and that could be extendable in lung or some other organ, then we call it generalizable application. So you should keep in mind that this whatever solution you are proposing, that should be generalizable as well. So yeah, this is some we have discussed about radiomic. Also, we have touched radiogenomic, and we have seen different applications areas based on who new classification of 2021 by who CNS tumors. And yeah, images are more than pictures. You can go through that publication. It's a great publication. Thank you. Hello. Is there any question? Hello.
Yeah, so thank
Yeah.
you so much for your informative talk on radiomics. You have discussed about the importance of radiomics and its applications. Participants, now if you're having any query, you
Mm-hmm.
can write it in the chat box. So they can only write in the chat box.
Okay. Okay. Great.
Just see.
First difference can substitute.